Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor, or welcome back. I'm here this evening with Dr. Kevin Lamb. Dr. Lamb is a practicing surgical podiatrist, foot and ankle surgeon here in Naples, Florida. And we're actually welcoming him back because he's been on our show before. And I'm here with Jim York, my co-host. And this is a show, as you may or may not recall, where we talk to physicians about their practices and about what they're doing in their practices. So it's good for viewers to learn what's going on and what the current standard of care is. And we'll be talking about reconstructive surgery in adults and in pediatric patients, and something called the Lamb bunionectomy, named after Dr. Lamb. But welcome back.
Welcome back, Dr. Lamb. Maybe you could just tell our viewers again your background and where you're located, and I know typical the different hospitals you're doing surgery in.
Well, I graduated from Temple University, School of Podiatric Medicine, and I trained over in Temple University as well as Mount Sinai Medical Center, and in addition to that, Jackson Memorial Trauma Center, before I came over to Naples. And it's been about 9 years now, and we have about 3 locations in Naples. One downtown at 661 Goodlet Road, one in North Naples behind North Collier Hospital, and one on the East Trail across from Lely Resorts.
So you went from Temple in the Northeast, and then you were in Miami?
Yes.
And what part of training was what?
Well, the Temple University was the school and the internship where we rotate through, and then the residency was down in Miami and Mount Sinai, South Beach, and Jackson. Mm-hmm.
And how long does that take?
Well, the whole time took about a total of 3 years, and then the school was 4 years.
A lot of time.
A lot of time, yes.
And I know you set certain time in the hospital to do surgery. Maybe you could just tell us a little bit about that, because that's unique to our area, isn't it?
It is. For myself, I have a OR dedicated to just myself on Fridays at Naples Community Hospital. We're the only podiatrist or podiatry group that has that time. My partners also have another day, and they share that day, for they're not as busy as I am. But the benefit of that is when patients come in for elective foot surgery, they're not going into an OR that was dealing with a colon case before. So there's less risk of infection, cross infections in our operating room. And our anesthesia and nursing staff, they're very familiar with my procedures because I do them day in and day out, every week. So they're very familiar with what's going on.
So it's nice you formulated a team, basically. That you all work together and everybody knows how each of you work.
Correct.
Right.
That's great for the patients because from pre-op area to operating room to post-op, everyone's on the same page every week.
And all the instrumentation is different for different surgeries, so they know your instrumentation.
Correct. Once they see the procedure up there, they can predict what I need. So less running around getting me instruments, so everything is right there.
And you're busy enough to where you have a full day, but your 2 partners, they have a separate day completely?
Correct. They have a separate day completely where they do cases, yes.
Wow. So you have specialty training in surgery more than, or at least in my experience, more than many podiatrists. Can you tell us about that?
Yeah, there's a big difference in the world of podiatry, and I would say in the United States right now, there's only 900 of us right now that are double board certified to do reconstructive surgery. So what that means is, we take extra time and extra training to do those difficult cases, such as an adult flat foot procedure, or a pediatric flat foot procedure, or a clubfoot procedure. Something that people might have heard of, like a Charcot foot for diabetics. That's what we do. And we spend extra time in training and dealing with those kind of complicated cases. And a lot of times we train with either orthopedic surgeon or a podiatrist, so we get a well-rounded view of how to treat patients with those kind of complicated issues.
So I assume people even from other areas are coming in to have you do surgery.
Yes, we've had people as far away as Ohio or out of the country even come in for our expertise.
Interesting.
And you were saying earlier off camera, you're starting to have physicians coming to train with you?
Yes. Well, we always had medical students come through, DPM and MD medical students come through, but recently we've been approached to actually do a training program for post-residency physicians, surgeons, either they're orthopedics or podiatrists coming out, but they have to be after residency. So that's another step above to give them concentrated complex cases for them to do for the whole year. And so far there's only about 12 of them, and we're number 13 in the country to be able to give those kind of programs.
So that would be a fellowship training? Is
Yes.
that what that?
That would be a fellowship training.
And you would be actually training podiatrists and orthopedic specialists?
Correct.
Both?
And yes.
That's pretty impressive.
Well, I think I've been blessed with having the opportunity to learn under some of the biggest names in our profession, as well as orthopedics and podiatry.
Yeah.
So it's about time to give back.
So we'll be talking about pediatric and adult reconstructive surgery. And so where would you like to start?
We'll start with the adults. The adult, we see that a lot in Naples. Here we have a lot of very active middle to older population. And it's great. It's awesome that they're very active. But that also gives us more degenerative joint disease to deal with, more tendinitis or tendon ruptures or injuries to deal with that are not as prevalent in other areas of the country. So in that regard, we get a lot of variety, such as adult flat foot. And how does that differ from pediatric flat foot? Well, typically for pediatric flat foot, you're born with it. Adults, they could be born with a nice arched foot, but over time, either through an injury or just through weight gain and excessive activity, one of the tendon that goes around the ankle goes into the foot, starts to give way, and your arch starts to collapse. And that's an adult acquired flat foot, and that becomes a big problem because that's a tendon problem, and we need to address that.
So can you show us what you mean by that? What holds the arch up? And there's a tendon you're saying that comes around this way?
Yes, that's a very important tendon. Unfortunately, there's only one of those that comes right behind this called a tibia. It's going to come right about here. There's even a groove for it, and it goes into this bone called the navicular right here, this little notch on the side. That one tendon holds the arch together. I'm going to exaggerate it right here. And when that tendon goes or is insufficient or dysfunctional, you collapse. And that's where you see the flat foot. People getting a flat foot, the foot splays out the other side, and you're pretty much not using your ankle, and you're degenerating and collapsing at the back of the foot. And that's why they call it adult acquired flat foot.
Is that something that occurs over time or acutely, or how does that happen?
Majority of the cases, it happens over time because you start with a tendinitis, you progress to a tear, and then you progress to, once the tear starts, then it becomes insufficient in strength to hold up the arch. Then you start collapsing the arch, and the joint starts to collapse. So typically, we like to see these patients when they're initially having tendinitis. That way, great. That's before your tendon tears. That's before you have your joint collapse. So if they just come in with tendinitis of that particular tendon, a lot of times physical therapy and mobilization is sufficient because the tendon hasn't torn yet and the joint hasn't collapsed yet. So there's no surgery involved if we get the patient early.
What would be symptoms of tendinitis in that area?
Tendinitis in that area, the symptoms would be pain along the tibia, or right about here, pain along the tibia, or we have pain along the navicular bone, this bone right here. This is the inside of the foot. As patients always tell me, the inside, we call it medial and lateral in our medical terminology. But pain along the tibia in the back or pain along the navicular, this is where the tendon runs. So anywhere along here where you have pain. And one common complaint that I hear from patients, Greg, is that they come in and say, hey, doc, I used to have an arch. And I noticed it going down, and that's one of the complaints. Or doc, I can't push off. I have a problem pushing off. And they think it's their Achilles. And it makes sense, but it's really the posterior tibial tendon is one that we see a lot of problems with in this community, and that's something that needs to be recognized and treated early to avoid the reconstructive surgery.
What's the most cause? Running or you can develop this from?
I say here is more like a weight gain.
Weight gain.
Weight gain, and doing too much, putting pressure,
Right.
excessive weight, and poor shoe wear. I mean, we see a lot of patients that are wearing competition running shoes for their everyday walking. Well, those are very light and very flexible. Well, they're for
Right.
competition. They're not for everyday walking.
Right.
So you need to really get walking shoes. And for people who have slightly low arch anyway, a nice over-the-counter insole or even a custom orthotics can keep them from having this problem.
So go ahead in terms of how would you repair that?
Well, when we get to the late stages of this disease, it's when the person's already collapsed already, the joint is almost like a loose bag of bones in here when they start walking. The patient will see that they're walking on the navicular or the talus bone. On the inside, they'll see a big bump here on the side.
Mm-hmm.
And they'll say, "Doc, what is that?" "Well, that's your bone. You're walking on your bone." And basically what we do in surgery now, we have two different ways of taking care of this. My criteria is not a hard-written rule, but just from experience and practice. If a patient is over 250 pounds, we'll go ahead and fuse the joints. Fusing meaning taking away the cartilage right here, taking away the cartilage here, and putting this foot that is a loose bag of bone back into this anatomical location. And freeze it with screws and plates so that it becomes one solid unit.
Right.
Now, patients will say, "Hey, doc, am I going to gimp for the rest of my life because you fused it?" And the answer is no, because these joints really are not supposed to move a lot anyway. You have a little bit of motion, but these people have excessive motion by the time this tendon collapses.
Right.
So we go ahead and we put them back in place. Yes, you lose the little motion you have, but it's better than having excessive motion and having all the other joints start to dislocate.
So these, I'm gonna hold this differently just for the camera. So what you're saying is these bones in the midfoot here, they don't move much anyway.
Tip it this way more.
That way?
This
Tip it that way.
So they
There we
can
go.
see like
Yeah,
that.
yeah, there we go.
Well, this is anatomically for us, this is the forefoot, the midfoot, and this is the hindfoot back here, more like the ankle. Patients always get that confused, the ankle or the hindfoot. So a patient will say, "Oh, it's my ankle." Okay, fine. I go along with that. It's the ankle. So basically, these dislocate, but these joints really don't move much anyway anatomically. And where we're having problem is when patients have that tendon laxity and all these joints start going out of place and dislocate. And that's what we see on the x-ray, is this dislocation of these joints like this.
Like that.
And a patient's foot will look like they're walking like a duck, they're walking
Right.
out. And that's how it happens. The beauty of the foot, the architecture of the foot is very amazing because every joint is going to affect another one. And so when these joints collapse, naturally, all these foot bones go out like this.
Right.
And that's where we see that presentation when patients come, they're standing up and the foot is going out the other way, or they're walking like a duck, they will say. And a lot of times we see this in one foot versus the other in adults, because typically we have one dominant foot over the other. So that's the fusion procedure for people who are over 250 pounds. But for the lighter patient or patients that are older that can't undergo this reconstructive surgery, the fusion, because I have to put them in a cast for about 3 months, there is another procedure that was actually one of my professors came up with this a long time ago, putting a bone plug, a metallic plug or bone plug right into this joint right here. This joint lifts up the joint of the hindfoot so that the patient don't collapse. So if we can see it from here, if I can show this correctly on camera, so if they collapse, this joint is going down. I stick an metal implant or bony implant in here. That holds it up in position so that the ankle does not, patients think it's the ankle, but the hindfoot does not collapse. And that procedure is, when it was first invented, it was invented for a pediatric flat foot, but now they've refined this implant to work more for adults, and that has helped a lot of our patients, the senior population, who can't undergo the 2 or 3 hour anesthesia, or they can't stay off their foot for 3 months because they have a backache or back pain in addition to the collapsed foot. That's a very good alternative for some of those patients. We're able to put this implant in, 2 weeks off your foot, they're walking in a boot right away, and they get out of that boot in about a month, and they have an arch.
So why is the recovery quicker on that? Because you're not actually breaking bone, you're just placing this spacer?
Pretty much. We're not. The reason why 3 months versus 2 weeks is because we're not requiring the bone to heal when we do this procedure. We're just putting a stent, putting a door stop, as I explained to patients. We put a door stop in here to prevent it from collapsing.
Right.
It holds the foot up, holds the joint up. Versus the other one, the 3 months, is because we're cutting the joints, taking the cartilage out, putting plates and screws across them so that the bones will think they have a fracture and they mend together. So in essence, we're creating a fracture, making the body think that, hey, I have a fracture, now let's start healing this to make it into one bone.
We're going to take a short break, and then we'll come back and talk more about pediatric and adult reconstructive surgery in just a few minutes.
Thank you.
Good.
When picking a realtor, don't just pick anyone. Pick someone with experience. Pick someone with a proven track record. Pick a realtor like Jim York from Downing Fry Realty, the #1 brokerage with the most real estate transactions in the area.
My husband and I had very specific ideas about what we wanted in our new home. Jim York was able to help us find the home that was ideal for us.
With over 20 years of real estate experience in Southwest Florida, Jim York has negotiated over $200 million in sales contracts. Selecting the right realtor is a critical decision that can earn you thousands when selling or save you thousands when buying.
Jim also helped us with a mortgage lender and a good real estate attorney. He went that extra mile, and his experience says it all.
Call Jim York for a no-obligation meeting at 239-273-6727 or visit his website, www.naplesyorkrealestate.com.
Welcome back to Dialogue with the Doctor. We're here this evening with Dr. Kevin Lamb. He's a practicing foot and ankle reconstructive surgeon, podiatrist. He does a lot with surgery. He does a lot of surgery that has never been done before. So we're talking about pediatric and adult reconstructive surgery. We just got finished talking about adult, and I think you said you were going on to pediatric.
Yes, we'll talk about pediatric flat feet. That's the thing that when the parents come in with their kid and all concerned, hey doc, my kids have flat feet, what am I going to do? Now there's a whole range of answers for that. A general guideline that's published by the American Association of Pediatrics, as well as American College of Foot and Ankle Surgeons, in conjunction with the American Orthopedic Society, they came up with a guideline for treatment of pediatric flat foot. Now, my own son has it, so hopefully he's not embarrassed by me saying that. So I didn't have to do surgery on him, and I tell parents, don't worry, majority of the time we don't do surgery for kids with pediatric flat foot. The criteria is if they're flexible and they're not painful, we just recommend anywhere from good shoe wear, proper shoe wear, teach them about proper shoe wear, and potentially custom orthotics in the mid-range. If they're flexible and have a little bit of pain, we'll get them custom orthotics. A step before, more than that, if they say, doc, you know, I've tried the orthotic and it still hurts, my son is still limping or my daughter's still limping, then we move ahead to surgical intervention. That's the recommendation. And a surgical intervention can go anywhere from the stent, like we talked about for the adults, which was originally made and invented for kids. The stent works really good for kids. They're very tolerant of that. And some studies have shown that the bone, if we get them young enough, the bone actually adapts around the stent so that they'll actually form an arch in the long run as an adult, and we could take that implant out if it bothers the child as they're growing up. Another tried and true method for kids, if they have painful pediatric flat foot, to avoid them having painful adult flat feet at that point, not acquired but congenital. That means they're born with it. We do see adults that had pediatric flat foot that was never treated. Now they're coming in with a whole host of problems. But for kids that are painful, that we can treat surgically, a very easy procedure that works really well. Now, we went over before how the foot looks when the foot is flat. All these bones go out this way. They're walking like a duck. So our goal at that point is I could put a little bone block right here on this calcaneus, the heel bone, and I can go ahead and...
Sorry about that.
No, it's okay. how we get the best view.
Camera 3 is where,
Right here for the best view, right here. That's what happens when a kid has flat foot, and adults too. So I would go ahead and make a little cut in this heel bone, put a little wedge of bone graft in here that we have at the hospital, and I'll swing that foot back underneath the ankle and the leg. That makes a huge difference for kids for the rest of their life once we get that in. And the recovery for that is 4 to 6 weeks off their feet in a cast and in a boot. The kids will heal very fast and adapt very well. And that could prevent our adult congenital flat foot pain syndrome.
So for the child that comes in to see me, or the parent that brings a child that comes in to see me, and they say they're flat-footed but there's no pain, they're not really having any problems, you're still recommending that they be evaluated because you're trying to do some preventative treatment.
Correct. Number one, we talk about the shoe wear. And yes, for some of these patients, they may not be painful. They could be hyperflexible, not painful. We determine the degree by measuring on the x-ray. And yeah, custom orthotics for these patients will definitely help them in the long run to prevent a dysfunction of the tendon. I mean, I had a 17-year-old child, very active in high school. And this is almost, luckily it turned out great. It would have been a very sad story. He's very active. High school kid, and his mother went through 2 or 3 other doctors in town, podiatrists in my field, but unfortunately they're not used to dealing with this, so the answer was, deal with it, wear the orthotics, deal with it. And when the mother found me through a friend of theirs, where I've done reconstructive surgery, I looked at the kid. He actually had a nerve impingement by that time and a tendon issue at that time. So no longer a pediatric flat foot case now. It's an adult flat foot case now, even though he's 17. He's impinging on that nerve right behind the tendon, the tarsal tunnel. And this kid was in a lot of pain. He was limping into my office. So at that stage, I went ahead and luckily it was a child. The joint was not degenerated. At that point, we did the bone block and ended up great. And the other foot started to go bad. So I said, Mom, let's go ahead. We caught this kid early this time. Put a plug in the other side, and we did, and we're able to save both feet at that point at age 17, and he's back playing football, and he's very active again.
And that the plug procedure or the stent procedure is the one you said earlier that doesn't take weeks in cast?
Correct.
It's a relatively short recovery time?
Yes, relatively short recovery time. That is the door stopper procedure, as I tell my patients. And it works really well for kids and adults under 250 pounds.
Very good. Very good.
And Narn, you want to talk about your other procedure you do?
Oh yes. I started to do. And actually in our field, we started to move toward minimally invasive surgery. And in Southwest Florida, where patients are like, okay, doc, when am I going to be able to get back off and playing tennis? It's very important to them. So, and very important for them to be independent, both from a psychological standpoint and from a social standpoint. So to do an old-fashioned bunionectomy, put them in a cast, put them on crutches or a walker for about 6 to 8 weeks, may not be a possibility for them. Another thing is if the keloid, that long incision on top of the foot, does not work well for them either. So there's this minimally invasive bunionectomy that's available, and I started to do that. And the nurses at the hospital started to call it the lamb bunionectomy because they've never seen anyone else in the hospital do it. They see me do it, and they're very impressed because the incision is literally about 5 millimeters. I'm able to do everything through the x-ray. The cut is very precise, guided with the x-ray, and the fixation is just a pin that I take out. So the patient has 1 stitch, 1 wire that is not kept in them, and they're walking right out of the surgery from day number 1, and very little bit of pain. Actually, they don't have any pain for 24 hours the way we numb them up. And our anesthesia staff does a wonderful job in managing perioperative pain or discomfort, actually, for these patients.
So a bunion would be on this over here on this side of the foot where the big toe is?
Correct. That's a bunion. That's the classic bunion is when we see how they make fun of it in the movie, the grandma bunions and etc. So this bone will actually go out, and this big toe will go underneath the second toe. We've all seen that. We've all seen that out in the streets in the supermarkets. Yeah. And that's a bunion. We also have a tailor's bunion on the other side too. On this side right here, the tailor's bunion because tailors sit on the side, and they have a bump on the outside.
Right.
This bunionectomy works great for both. The 5mm incision, I'll go ahead and make a cut underneath the skin, straight across, shift the bone from here over. Same thing here, I cut the bone here, shift the bone over. Now, that takes away a couple of fears of patients, traditionally for bunions. Patients always say, hey doc, that's the most painful surgery I've heard. I don't know where they heard that from, but with this procedure, there's no collateral damage. We're not taking out any tissue. Whatever bump on the side you were born with, that's still there, is rotated and moved in. And we're actually correcting the angle of the bone, not just taking off the bump. And that gives you a long-lasting correction, in addition to the fact that all your soft tissue is intact, so there's no excessive bleeding or bruising or nerve damage. So the patients don't have much pain, which is the biggest fear when they come into my office. They are nervous when they talk about bunionectomies.
So you're cutting the bone and then pushing it over and then pinning it?
Yes. I cut the bone, I shift this bone, shift the top of the bone over, and then I realign the big toe straight. Because in a bunion deformity, this big toe right here is going over in this very severe case. That's how it looks on the x-ray. And so cut the bone, shift it over, and all's done through a 5mm incision, and the soft tissue envelope keeps everything together. So we're not, so the bone's just not flying all over the place and is very stable, whereas the traditional bunionectomy, we open the incision up and you have a lot of soft tissue that we have to dissect, and there's a chance for that fragment to loosen. With this procedure, there's no chance of that happening.
So there's special instrumentation required to do that?
No, we have all this instrumentation in the hospital. It's just a technique. We use very minimal amount of power instrumentation. We use a lot of hand instruments, so that way we don't cause burning of the tissue, which translates into quicker healing and less pain or discomfort for the patient post-operatively.
So they're in and out, basically.
They're in and out the same day.
Same day.
Well, I think that's phenomenal, because I think patients, you know, there's a reputation that foot surgery requires this huge healing time, and you've shortened this healing time.
Definitely, we've shortened the healing time significantly.
Yeah. So.
Well, I think it's exciting, all the stuff you're doing, and we have it here in Naples, Florida. And we'd like to thank you for coming on and supporting us here at Dialogue with the Doctor.
We not only have it here, we have you that developed it, and now it's named after you.
Well, thanks for the invite.
Thanks for coming.
Thanks
for coming.